Welcome to Triage Cancer's webinar, Medicare 101. I'd like to introduce you to our speaker for today. Amanda is a staff attorney at Triage Cancer. Prior to joining our organization, she spent more than a decade counseling seniors and caregivers about Medicare and related benefits, and was also a certified New York State Health Insurance Assistance Program counselor. If you would like to read more about Amanda, you can do so on our website.
Thanks so much, Sophia, and thank you everyone for joining us today for Medicare 101. So our goal is to provide a solid overview of the Medicare program, whether you are someone who is completely new to Medicare or whether you're someone who has some experience with Medicare but is looking for a refresher on that topic. So I'm going to start. I wanted to show you a roadmap of what I want to cover during our time together. And I'm laying it out at the onset because I know with Medicare, I see already there are questions in the Q&A box and people are anxious to get their questions answered. I just want to make it clear, I am going to try and cover a lot of different topics. So if you are asking a question about a topic that I think I'm going to get to later on in the presentation, my colleagues may hold off on answering because they know that I will be answering some of these questions, in the course of my presentation. So today, I'm going to start out with a relatively quick review of some common health insurance terms, and then I'm going to get right into Medicare. I'm going to talk about the different parts of Medicare and what each of those parts covers and what each of those parts costs. Then I'll move into talking about Medigaps and using them as a strategy to minimize out-of-pocket costs. Then I'll talk about enrollment periods, the different periods of time during the year that someone can enroll in parts of Medicare and or switch how they get their Medicare coverage. Then I'll talk briefly about some strategies about what you do if Medicare says no. And we'll end up with a conversation about financial assistance programs that are available to help people to pay their Medicare costs. And so one of the first things that everyone wants to know about Medicare is, what is it going to cost? So I'm going to get into that in detail. But before I do, I want to make sure we are all on the same page with respect to the meaning of terms that are used across all types of health insurance to describe what that health insurance costs. So first, there is the cost just to have your health insurance to begin with, and that is a premium, a fixed dollar amount that someone is paying each month just to have coverage. You are paying the same premium whether you are seeing multiple doctors every week or whether you are spending the entire year without ever seeing a doctor. Then there are the costs when you're actually using your health insurance. There's a few terms used to describe this. First, there's the deductible. Again, a fixed dollar amount that someone is going to pay out of their own pocket at the start of the year before their health insurance kicks in and starts to share in costs. Deductibles range. They can be super high, they can be super low, or even zero. So a plan with a $0 deductible is going to start sharing in your health insurance or healthcare costs the very first time you get healthcare. Then there's a cost each time you actually go and get care, each time you go and see a doctor or you fill a prescription. And that cost can be expressed in one of two ways. It can either be it can be a fixed dollar amount, in which case it's called a copayment, or it can be a percentage, in which case it's called a coinsurance or a cost share. So if each time I go and see my primary care physician, I pay $20, that's a copayment. If each time I go and see my primary care physician and I pay 20% of the cost of the visit, that's a coinsurance. And then the final term related to costs that I want to make sure we all are on the same page about is out-of-pocket maximum. Once someone reaches their out-of-pocket maximum, their plan is going to take over and pay 100% of their covered costs for the remainder of the year. So to figure out what amounts you're spending count towards that out-of-pocket maximum, you have to read the terms of your plan or understand how you're getting your health insurance. So just as an example, if you have health insurance you purchased on your state marketplace, everything that you spend towards your deductible, all your co-payments, and all your co-insurances are going to get added together to count towards your out-of-pocket maximum. A very quick example of how this is working in practice. Here's Dan. Dan purchases an individual health insurance plan on his state marketplace. Plan has a $2,000 deductible. It's structured as an 80-20 co-insurance plan where the plan is paying 80% of expenses and Dan pays 20% out of his own pocket. And the plan has an $8,000 out-of-pocket maximum. Dan ends up in the hospital at the beginning of the year with a $102,000 bill. What is he responsible for? He's first responsible for the $2,000 deductible, leaving a balance of $100,000. Then his co-insurance amount is 20% of that, or $20,000. And then, because his plan has an $8,000 out-of-pocket maximum, he's already paid $2,000 towards that. There's $6,000 left, and so he owes $6,000 of that remaining $20,000. The $6,000 co-insurance plus the $2,000 deductible, he satisfied the entire out-of-pocket maximum at $8,000. A lot of money, no doubt, but still a lot less than 20, let alone 100 or 102,000. And that example is in our animated video about health insurance basics in case you know somebody who would benefit from hearing it. Maybe you're working with a patient who would benefit from hearing it. All of that, again, is background for today as I get into talking about the costs involved with Medicare. So now we have this basic terminology under our belts. Let's talk about Medicare. Medicare is the public health insurance program that is available for US citizens and for certain legal residents who fall into one of a few categories. It is for people who are 65 years of age or older. It is for people who have been receiving Social Security disability insurance benefits for at least 2 years. And it's also available for people who have end-stage renal disease or ALS. Medicare is divided into different parts. So we're going to go over what each of these parts is. Medicare Part A is hospital insurance. It is what covers things like an inpatient stay in a hospital, an inpatient stay in a skilled nursing facility. It covers certain home health services. It covers some very limited nursing home care. And Part A is also where you're going to find Medicare's hospice benefit. What does Part A cost? So just a note before I talk about any costs, all of the dollar amounts that I'm going to talk about today or that you see on my slides, unless it says otherwise, these are amounts for 2023. And that is because usually the amounts for next year, like the 2024 amounts, they're not going to be released by Social Security or by CMS until later in the fall. As soon as we get updated amounts, we will be updating the resources accessible on our website. So please do check back and you'll see our quick guides updated and our other information in cancer finances updated. But for now, we're going to talk in 2023 numbers. So generally speaking, if someone has worked and paid into the Social Security system, Medicare Part A is premium free. There is no monthly cost just to have it. If someone hasn't paid into the Social Security system or they haven't paid in for long enough, they can still get Part A, but they are going to have to pay a premium for it. And the amount of that premium is going to depend on what kind of work history they do have. It's going to depend on how many work orders or credits they have with Social Security. Medicare Part A, even if you get it premium free, okay, it still has other costs that everyone has to pay. So Medicare Part A has a deductible. The deductible for Part A is a little different from most health insurance deductibles. So most of the time when we talk about health insurance and a deductible, we talk about a calendar year deductible, but Medicare Part A's works a little differently. The deductible is $1,600 per benefit period. A benefit period starts the first day someone is admitted to a hospital or a skilled nursing facility. And it ends when that person hasn't been getting any inpatient care for 60 days in a row. So depending on someone's health situation, it is actually possible they could have multiple benefit periods within the course of a year and thus be responsible for paying that Part A deductible more than once. Part A also has co-payments. The co-payment amount is based on the number of days that someone has been in a hospital or other facility. And then, if you are not eligible to get premium-free Part A, and you don't buy Part A when you are first eligible to do that, you could face what's called a late enrollment penalty. If you have a late enrollment penalty, it means that that monthly premium that you have to pay is going to go up by 10% when you do decide to enroll in Part A. And then you have to pay that higher amount for twice the number of years that you could have had Part A, but you didn't sign up. So for example, if you were eligible for Part A for 2 years and didn't sign up, and again, that's only if you had to pay for Part A. If you have premium-free Part A, you don't have to worry about this. But if you were eligible for Part A that you had to pay for 2 years and you didn't sign up, you'll have to pay the higher premium for 4 years. Medicare Part B is what I'm going to refer to as medical insurance. This is the part of Medicare that covers things like a visit to a doctor or a lab test or a physical therapy appointment. It's what covers preventive care and basically everything that you think of as outpatient care. It also has a home health care benefit to it, and it's also the part of Medicare that covers durable medical equipment. Even if you are someone who gets Medicare Part A premium free, Medicare Part B has costs, including a premium. So this year's monthly premium for most people is $164.90. Excuse me. If Medicare considers you to be somebody that's high income, which this year Medicare, when they say that, they mean an individual who makes more than $97,000 a year or a couple at $194,000 a year, then your monthly premium is higher. And the amount is going to depend on exactly how much money you're reporting. Medicare Part B does have a deductible. It's an annual deductible, the kind that everyone is used to. This year, that number is $226. And it's structured as a cost share. It's 80-20. Medicare pays 80% of costs. The individual pays 20% out of their own pocket. Unlike with most plans people are used to, like employer-sponsored plans and marketplace plans, there's no out-of-pocket maximum. So if you are someone with a cancer diagnosis or another serious health condition, costs can really add up. I am going to talk in a little bit about some strategies to control that. If someone doesn't sign up for Part B when they are first eligible, they also may have to pay a late enrollment penalty. And that late enrollment penalty, if they have one, lasts as long as someone has Medicare, with very limited exceptions. If you have a Part B late enrollment penalty, your monthly premium goes up 10% for each full 12-month period that you could have had Part B, but you didn't sign up for it. Parts A and B of Medicare together are what we call original Medicare. And that's because that's all of Medicare that existed back when it was signed into law in 1965. Original Medicare is what we call a fee-for-service health insurance system. So fee-for-service refers to health insurance where services are not bundled together. Everything is paid separately as people receive the services. Fee-for-service plans give people the greatest choice of providers. So if you have original Medicare, you can see any provider, go to any doctor, go and get care at any hospital throughout the United States, as long as that is a provider that accepts Medicare. The other type of healthcare payment system that we have in this country and that people tend to be very accustomed to is the managed care system. That's a system where you have private health insurance plans contracting with networks of providers and pre-agreeing to the cost of different kinds of care. The Medicare Advantage program, which I am going to talk about in more detail shortly, is a managed care program. Before we get to Medicare Advantage, though, I'm going to jump over to Medicare Part D, which is Medicare's prescription drug benefit. So Part D became effective in 2006. Between 1965, when Medicare first started, and 2006, Medicare had no drug coverage for people. So in 2006, we get this new program, the Part D program. It's made up entirely of plans from private insurance companies. Each of these plans can have different premiums and different deductibles and different cost structures. This year, in 2023, the maximum deductible a Part D plan can have is $505. The premiums range, so they can be super low in some areas, under $10. They can be super high and over $100. They average out around $32, $33 a month. Each plan has its own list of drugs that it covers and its own pricing structure for those drugs. And just like with premium Part A, when you have to pay for Part A, and just like with Part B, if you don't enroll in a Part D plan when you are first eligible to do that, and you don't have what Medicare calls creditable coverage, you may have to pay a late enrollment penalty. And again, that's a late enrollment penalty that's going to last as long as you have Medicare, with limited exception. So what does it mean when I say unless you have creditable coverage? That means coverage at least as good as what Medicare is offering. And Medicare has all these different rules about what makes coverage creditable or not. If you are someone who, for example, is currently working and have drug coverage through your employer, you can go to that plan, you can call that insurance company and ask your plan to tell you whether or not your coverage is considered creditable for purposes of Medicare. If you are someone who ends up with a Part D late enrollment penalty, this has its own calculation. It's 1% of an amount that Medicare determines. Medicare calls it the national base beneficiary premium. You can see this year it's $32 and change. You multiply that times the number of months that you were eligible for Part D, but you didn't sign up. So some terms that are important when you are thinking about prescription drug coverage. The first one is formulary. Really, that's just a fancy way of saying the list of drugs that are covered by your plan. Formularies get broken down into different levels or tiers. And the number of tiers varies by plan. There's no, set rule about the number. In general, the lower numbered tiers are where you are going to find things like your cheapest generic drugs and your lowest copayments. And then the higher numbered tiers are where you will find things like specialty drugs, newly approved drugs, a lot of the drugs used to treat cancer. And you're either going to find a much higher copayment or even more likely a coinsurance amount to go along with that. If someone is looking to fill a prescription for a drug not on its plan's formulary, that person's going to be responsible for paying 100% of the cost of the prescription. And whatever they pay is not going to count towards their deductible or towards their out-of-pocket maximum. So as I mentioned, for a really long time after Medicare came into being, there was no drug coverage. In 2006, we get prescription drug coverage, which is fantastic for people, but it wasn't, and it still isn't, a perfect program. So one of the major issues with Part D when it first came about is that if someone had really high prescription drug costs, they could fall into what was called the donut hole. This meant that there was this period of time during the year when someone had a gap in their drug coverage and they became responsible for paying 100% of the cost of their drugs, even though they had a prescription drug plan that covered the drugs. So this was a really big problem. And when the Affordable Care Act came along in 2010, it is one of the issues with Medicare that it tried to address. So the Affordable Care Act makes a number of improvements to the Medicare program. It adds a free wellness visit. It adds a bunch of different free preventive care services. And it works to close that donut hole for consumers a little bit at a time over a 10-year period. So that as of 2020, there is no longer a period of time when someone with a Part D plan has to pay 100% of their drug costs. So I want to show you a breakdown of what prescription drug coverage looks like this year. So the first thing someone's going to pay with their drug plan is their deductible, if their plan has one. And again, it's a maximum this year of $505. After their deductible is paid, the person enters what's called the initial coverage phase. And during this period of time, the person with Medicare is responsible for paying 25% of the cost of their drugs, and Medicare is covering the other 75%, okay? If someone's drug costs are high enough, though, when their total out-of-pocket costs reach $7,400, again, that's this year's number, that person will transition to a new phase called catastrophic coverage. At this point in time, the person becomes responsible for only 5% of the cost of their drugs. Or if that 5% is actually a super low number, there are these nominal amounts that they have to pay, would have to then pay for generics or brand names. Just a note, when I say their total out-of-pocket drug costs reach $7,400, that doesn't mean that the person themselves has paid all that money themselves. It means that what they've paid, plus the value of any discounts that drug makers are required to provide on brand name drugs, reaches that amount. So usually from different studies, the amount that the person with Medicare has spent up to this point is around $3,100 on brand name drugs. There are, however, some changes coming to Medicare Part D for next year and for the years following that. And I'm sure a number of you are familiar with some of these. So last August in 2022, President Biden signed the Inflation Reduction Act into law. Beginning in 2024, that 5% catastrophic coverage payment that I just described is going away. Once total out-of-pocket drug costs reach, and so for next year, the number I've seen is $7,750, but the final number is not out yet, but we're going to just estimate that. Once total out-of-pocket drug costs reach that amount, someone with Medicare is no longer going to have to pay anything for their drugs for the remainder of the year. So effectively, we're going to get this out-of-pocket maximum on drug costs that we have not had before. And once you include the discounts that the drug makers have to provide on the brand names, it means that effectively for a consumer, they should be maxing out at paying around $3,250 total for their brand name drugs. Again, a lot of these numbers are estimated. We don't know yet what the final numbers will be. Okay, then in 2025, there's going to be a flat out-of-pocket cap for drug costs at $2,000. That $2,000 cap is going to apply whether someone has a Part D plan or whether they have a Medicare Advantage plan that includes drug coverage. If the plan has a deductible, what is paid towards the deductible will count towards achieving the cap. And of course, the cap is expected to increase over time. The other big thing happening in 2025 is that people are going to be able to ask for a payment plan to spread out their out-of-pocket costs over the year. And there's a lot of details that are currently being worked out about this. CMS has actually issued regulations that people are commenting on to finalize how this whole program is going to work. So stay tuned for more details about that. A couple of things that the Inflation Reduction Act has already done this year for people. For those who are using insulin, the copay for a 30-day supply of insulin has now been capped at $35. Vaccines that are covered by Part D, like the shingles vaccine that I know has been expensive in the past, now have no cost sharing. And also, for the next several years, Part D plans are not going to be allowed to increase their premiums by more than 6% each year. So even though we're now going to have this cap on out-of-pocket expenses for people who are worried that the premiums are going to skyrocket, there is this control over what's going to be happening with them. So far, just to recap, we have talked about Medicare Part A, which is hospital coverage. We've talked about Medicare Part B, which we call medical insurance. We talked about Part D, drug coverage. What happened to Part C? So Part C is the Medicare Advantage program, an alternative to using original Medicare. Medicare Advantage is composed of managed care plans. They're sold by private insurance companies. And they bundle all of the services that someone would otherwise be getting under Medicare Parts A and B. And the vast majority also include Part D, drug coverage. And these plans operate a lot like the insurance that consumers are used to, the kind that they get through their employers and marketplace plans. Advantage plans can be structured a number of different ways. I'm going to talk about a couple of them in a moment. Each of these plans has its own network of providers. And then in terms of their cost, plan premiums, deductibles, cost sharing, all of it is going to vary by the plan. So if you're thinking about a Medicare Advantage plan, you have to look at the plan to know what all of these are going to be. However, there are a couple of points about cost that are consistent for all Advantage plans. So one of those is that by law, Medicare Advantage plans have to have an out-of-pocket maximum. So this year, the highest out-of-pocket maximum one of these plans can have for in-network services is $8,300. That out-of-pocket maximum is just for services that would have otherwise been covered under Medicare Parts A and B. So it's for medical care. This has nothing to do with Part D or drug coverage. And if your drug coverage is within a Medicare Advantage plan, this out-of-pocket maximum has nothing to do with that. The other thing to keep in mind that's important with cost is that even if you have a Medicare Advantage plan that has a monthly premium, you still have to pay your Medicare Part B premium. So any Advantage plan premium is on top of that Part B, this year $164.90 amount. So I want to highlight the fact that there are a ton of choices with Medicare Advantage. This year alone, there are just shy of 4,000 of these plans that are on offer throughout the US. On average, people are choosing among, call it, 40, 45 of these plans. There is one county in Ohio where someone can choose among 87 of these plans. Choice is, of course, a great thing, but this is it can be an overwhelming amount of choice. Even though these plans can have a number of different structures, most of these plans are either HMOs or PPOs. And even though there are so many of these plans, the market is dominated by a limited number of insurance companies. So you can see on the slide between United Healthcare and Humana alone, that's almost half of Medicare Advantage enrollment. Right now, around half of people who are eligible for Medicare are enrolled in Medicare Advantage plans, and that enrollment is projected to continue to increase so that as soon as maybe even next year, Medicare Advantage may be more common than having original Medicare. So I mentioned these plans can have a number of different structures. I just want to do a quick review of the two that are most popular, which are HMOs or health maintenance organizations and PPOs or preferred provider organizations. So HMOs and PPOs are similar in that they are both managed care plans. However, HMOs tend to have smaller networks of providers, whereas PPOs tend to have larger networks. PPOs also allow for some out-of-network coverage, which HMOs do not. Usually, if you're in an HMO, you are going to need to select a primary care physician. And then if you want to see specialists, you need to go through that primary care physician to get referrals. That is not something that happens in PPOs. You don't have to go and select a primary care physician. Usually, you're not going to be obligated to get referrals. The trade-off for that greater flexibility is that PPOs tend to cost more money than HMOs. So when we think about costs and we think about trying to compare these plans, how do we go about doing that? First, you got to gather some basic information about how it is that you calculate total cost of a health insurance plan, and then you have to do some math. So I have found that a lot of the time when people focus on the cost of their health insurance plan, they focus on the plan's premium, right? They focus on what they know is a fixed cost. But if I sort of refer back to that initial slide I went over about different health insurance terms related to cost, premium is only one of those terms. It's only telling you part of a story. And if you are someone with a cancer diagnosis, we're going to assume that you're going to use a lot of healthcare during the year. And if you're going to use a lot of healthcare during the year, there is a good chance that you are going to hit a plan's out-of-pocket maximum. And so as a result, when we compare plans, we want to look not just at monthly premiums, but how the premium and the out-of-pocket maximum together work. So I'm just using a basic example here, not even a Medicare example. I'm looking at the first plan on this slide, which is a marketplace plan. It's got a $200 monthly premium, $6,000 deductible, $8,000 out-of-pocket maximum. Then I have the second plan, which is an employer-sponsored plan, $275 monthly premium, $2,500 deductible, and $6,000 out-of-pocket maximum. And to compare to find out total expected cost of these plans, I'm going to do my math. In each case, I'm going to multiply my monthly premium times 12 because I know that I have that cost all year long. In the case of plan one, my marketplace plan, I'm going to add the out-of-pocket maximum amount to that amount that the premiums equal. I don't have to add my deductible because in a marketplace plan, what I spend on my deductible counts to getting me to my out-of-pocket maximum. In my employer plan, I've said the deductible isn't going to count towards my out-of-pocket maximum. So when I do my math there, I have to add up the $275 times 12 plus the $2,500 deductible plus my out-of-pocket maximum. And so you can see for each of these plans, right, there's a big difference of only looking at 12 months of a premium versus looking at 12 months of a premium plus an out-of-pocket maximum that comes into play. Now let's look at how this is all going to work in the context of Medicare Advantage. Meet Ted. Ted is trying to figure out his Medicare options. He's turning 65 and has leukemia. He lives in upstate New York. Ted has confirmed that his oncologist is in network for 2 Medicare Advantage plans in his area, but he isn't sure how to compare those plans. Ted knows he'll have a lot of healthcare costs this year, including 10 rounds of IV chemo, and his doctor has told him to estimate that each round will cost around $5,000. Which plan is going to cost Ted less money for the year? So to help Ted compare the 2 plans, I'm going to use a tool that we have developed to make this hopefully complicated process a little easier. It's our Medicare plan comparison worksheet. The first part of the worksheet lets someone fill in basic information about each of the plans so that they're going to remember which one is which. They can put in information like whether their providers are in network for the plan and whether this is a plan that's going to include drug coverage. I want to just note for all my examples today, I actually use real plans and real plan data to make the examples, but just understand that all the plans were chosen randomly. So by putting names of different insurers on the slides, I'm not trying to make a point about, endorsing one or saying something bad about another. So again, first part of the worksheet, we put down the basics about our two options. Then we have to fill in the cost-related information in the Part C plan costs section. So as I told you earlier, when it comes to Medicare Advantage plans, people are still responsible for paying their Part B premium. So the first thing that we put in there next to the letter A is that $164.90 amount. That goes under both option 1 and option 2. Then you have to fill in the Part C premium if the plan you're looking at has one. So in this case, our option number 1 is a 0 premium plan. That plan does not charge anything on top of the standard Part B premium, which seems like it should be a big cost saver. Our second option does have an additional Part C premium. That's $115 a month, and that is going next to the letter B on the screen. Some of the elements of our worksheet, if you put numbers in, they will automatically populate for you down below. Others you have to put in yourself. After you put in the premium amounts, you're going to fill in deductibles. In the case of these plans, they are both 0 deductible plans. And you're going to fill in out-of-pocket maximums. So our first option has a $7,550 out-of-pocket maximum. This plan is an HMO, and there is no coverage to see out-of-network providers. Then our second option is a PPO. It has a $3,400 out-of-pocket maximum. And what's interesting about it is this is the out-of-pocket max for both in and out-of-network coverage. So we put all of this in, we make notes as needed, and after we complete the middle part of the page, if the amounts have not transferred automatically, you're going to transfer the ABC amounts down to the bottom. What happens next is you're going to do the math. So option 1, you need to multiply $164.90 times 12. You're adding that to the second set of parentheses is 0. So basically you're adding the 12 times the monthly premium to the out-of-pocket maximum, and you get a total of $9,528.80. Option 2, similar math. You still have the Part B premium times 12. You add it to your Part C premium, again times 12, and you add that to your $3,400 out-of-pocket maximum. This time when you do the math, you get $6,758.80. So the PPO that has more flexibility in terms of the providers you can see, even though it has that additional premium each month, when you do all the math, it ends up being the less expensive plan for TED. So keep this in mind. We're going to come back to TED in a few minutes. Comparing the costs of the different Medicare Advantage plans is only step 1. Don't forget that there are other differences between the plans. That's why you filled in the answers to those questions at the top of the worksheet. So you want to make sure that you understand whether the providers that you want to see are in your plan's network. You want to understand if the plan has out-of-network coverage, and if it does, understand what it's going to cost. And also, you want to make sure if this Medicare Advantage plan has drug coverage, that you check and see whether the drugs you need are on that plan's formulary, whether that plan has a separate drug deductible, excuse me, as well as whether the drugs you need have any coverage restrictions on them. So as with anything, really, Medicare Advantage plans have pros and cons. You can see, some of the ones we've identified on the slide. I would say, to me, the most significant advantages to Medicare Advantage are they have this stated out-of-pocket maximum. They also have the potential to cover some things that original Medicare doesn't cover, like routine dental care and routine vision care, hearing aids. And also for some people, they like the fact that they're going to now get their healthcare all through one plan. They don't have to worry about a few different insurance cards or dealing with multiple insurance companies. To me, the most significant con or potential con to a Medicare Advantage plan is you are limiting your care to a network of providers. And you want to keep in mind that during the course of the year, even if you check and make sure that all of your current providers are in network for the plan you select, mid-year, if you have a change in your health situation and all of a sudden want to go and see a specialist, there's no way to know in advance whether someone you haven't identified yet is going to be in network for your plan. All things to consider. Sometimes people will ask, well, which is better? Is it better to have original Medicare and a standalone Part D plan? Or is it better to have a Medicare Advantage plan? And unfortunately, the answer I'll give is sort of a very lawyerly answer, which is it really does depend. Every individual's health circumstances are different. Their financial circumstances are different. Where they live is different and what might be available to them. So what works for you might not be what works best for your friend or your cousin or even for your spouse. Before I move on to our next topic, I do just want to highlight, again, a few of the things that original Medicare doesn't cover. So if you have original Medicare and you need the things listed on this slide, you're going to have to find coverage somewhere else or pay for them out of pocket. And these are obviously, like when we look at this list and we see long-term care and dental and vision and hearing care, dentures, routine foot care, these are all things that most people do need at some point or another. So I don't want to minimize the fact that original Medicare is not going to be the solution for them. So we already talked about the fact that with original Medicare, we don't have an out-of-pocket maximum, and Parts A and B don't pay 100% of someone's healthcare costs. So what do we do about that? If you have chosen original Medicare, you also have the option to purchase something called a Medigap plan or a supplement to Medicare. Medigap plans are private insurance plans that someone can purchase directly from an insurance company. Medigap plans pay for out-of-pocket costs from Medicare Parts A and B. Now, Medicare is a federal government program. It is the same program all across the country. Medigap, although it supplements Medicare coverage, isn't part of that federal program. Each state can actually have different rules when it comes to Medigaps that are sold in that state. So it's really important to understand what the rules are where you live. And one difference I'll just share right at the outset is if you live in Massachusetts, Minnesota, or Wisconsin, all the Medigap terminology that I'm going to show you on the next slide, those states operate a little bit differently. In the vast majority of states, they standardize Medigap plans using the letters you see on this slide, A through N, although a few of them are missing. And I'm just going to say at the onset, because people talk about how complicated Medicare is, and I sympathize, and I agree. I just finished talking about Medicare Parts A and B and C and D. And then this A, B, C, and D you see on this slide have nothing to do with that, okay? So in the world of Medigap, when we're looking at this slide, A, B, C, D, and all these other letters, they are just referring to different kinds of Medigap plans. In each state, Multiple insurance companies can sell each of these different lettered plans. If you are looking at a particular lettered plan, like you're going to look at Plan G, for example, no matter what insurance company is offering a Plan G, that Plan G has to provide the same basic medical benefits that you see in the chart on this slide. So just as an example, I'm going to pretend I'm looking at a Plan G and I find one insurance company that's going to sell it to me for $200 a month. And then this other insurance company is going to sell it to me for $300 a month. Even though there's $100 a month difference there, those two plans still have to offer exactly what is laid out in this chart at the percentages laid out in the chart. So how on earth is buying something else and paying another monthly premium going to save anybody any money? Each of the plans is going to pay the different deductibles and coinsurance amounts that you see at the rates that are shown so that the consumer doesn't have to pay those things out of their own pocket anymore. So if the consumer buys a Medigap Plan G, yes, they're going to have to pay the monthly premium for the Plan G, but they're no longer going to have to pay their Part A hospice care coinsurance or their skilled nursing facility coinsurance or their Part A deductible. So you see that I have like a separate narrow rectangular box on the side with plans C and F. That's because those plans are no longer issued to people who first became eligible for Medicare after January 1st of 2020. That said, if someone was first eligible for Medicare before that date, they can still have these plans or buy these plans. So the plans are still around and in existence. It's just if you're newly eligible for Medicare after the beginning of 2020, they're not options for you anymore. We are sometimes asked about, well, which one of these is the best one to get? And I'm never going to tell someone what's best for them. But what we can say is that the most comprehensive Medigap that is now available for someone newly eligible for Medicare is Plan G. And Plan G has two different versions. They have their regular version, and then they have a high deductible version. The high deductible version usually has much lower monthly premiums, but you have to meet a very high deductible. This year it's $2,700 before the Medigap starts to pick up your out-of-pocket costs. Let's just look at an example of how a Medigap can make a difference in someone's costs. So Jimmy is almost 65. He lives in California. He's weighing his Medicare options. He's about to start chemo that's going to last a year. And he's heard that his IV chemo treatment is covered under Medicare Part B. But Part B is that 80-20 cost share. His drug costs are going to be $10,000 a month. He's not interested in a Medicare Advantage plan because he spends part of the year in Florida. He wants a Medicare option with the lowest out-of-pocket costs. So Jimmy's first option is just getting original Medicare. He has to pay his Part B monthly premium. He has to pay his Part B deductible. And then he'll have his Part B cost share. So just for his chemo, we're talking about $10,000 a month. 20% of that, which is $2,000, times the 12 months of treatment. So that's $24,000 of that Part B cost share, and that's just the chemo. We're not talking about any of the other care that he may need. So when we add all that together, we are looking at over $26,000 in cost. Jimmy's other option is to think about getting a Medigap. So he prices a Medigap Plan G. I'm making up this, but it costs $300 a month, okay? So then when we do his math, he still has 12 months of his Part B premium. He still has to pay his Part B deductible. Now he has a Medigap premium. So another $300 a month times 12 months, that's $3,600. But by having that Plan G, it's picking up his entire Part B cost share. Now his total costs are just below $6,000. Jimmy is saving more than $20,000 by buying another insurance plan. So there are rules around when someone can enroll in a Medigap plan or make a change to their Medigap coverage. And I want to go through some of these. The first period of time that someone can enroll in Medigap is when they are both age 65 and they have Medicare Part B. When someone is both 65 and has Medicare Part B, they get a 6-month period when Medigap plans are what is called guaranteed issue. That means you can buy your Medigap and the insurance company can't engage in medical underwriting. It can't look at your medical history to figure out whether it wants to sell you a plan or how much it's going to charge you for that plan. They are guaranteed to issue it. Now, that's great, but what if you're under 65? What if you're eligible for Medicare because you've been getting SSDI for 2 years? In that circumstance, it is actually up to each state as to whether the state has rules that require the insurance companies to sell someone a Medigap. There are some states where there is no requirement that an insurance company sell a Medigap policy to someone under 65. And those states are identified on the slide. If you're in one of those states, it doesn't necessarily mean that you can't get a Medigap, but it means that there isn't an obligation that the insurance companies sell you one. So you could end up being denied, or you could end up being charged more money based on your health situation. The next period of time that someone can look at Medigaps is during fall open enrollment. During open enrollment, people have the opportunity to switch Medigaps without going through medical underwriting, as long as a few things are true. They can do that if they are staying in the same Medigap letter. So someone who has a Plan G offered by one health insurance company and finds out there's a Plan G being offered by another health insurance company for less money, they can make that change without going through medical underwriting. They can also make a change from a higher lettered plan to a lower lettered plan, like if they want to go from more coverage to less coverage. But if during open enrollment, you are someone who's never had a Medigap, or if you're trying to go up in coverage, you might have to go through medical underwriting, unless you have another kind of guaranteed issue right. So you could end up being charged more or denied based on your health situation. A plan can also impose what's called a pre-existing condition exclusion period, or a pre-existing condition waiting period, meaning that the insurance company will sell you a plan, but for as much as 6 months, that plan isn't going to cover services related to whatever conditions were pre-existing. So if you go to Medicare's website, you can see a list of all of the different circumstances where someone has guaranteed issue rights for a Medigap. Again, the right to buy a Medigap without going through medical underwriting. Also, some states have some additional rights, and you would need to find out about that, usually through your state's insurance department. I want to go back to Jimmy and just see what happens if he gets a Medigap, but he's subject to a pre-existing condition exclusion period. So Jimmy's first option is still the same, right? He can still just have original Medicare and not deal with a Medigap, especially if he finds out, well, it's not even going to cover my cancer for the first 6 months. And when we do that math, again, we're at that 26,000 plus number. He does have the second option of the Medigap. He's still going to look at that Medigap Plan G that costs $300 a month, but the math looks a little different now. He's still paying 12 months of his Part B premium. He still has to pay that full Medigap monthly premium, and he still has to pay his Part B deductible. But when we look at his cost share, again, that was the $10,000 a month chemo treatment, 20% of that, or $2,000. He has to pay that for the first 6 months that he has this Medigap. So that's $12,000 added on to the other expenses. After the first 6 months, the Medigap then will step in and pay for that 20% cost share. The total of these amounts is close to $18,000. Obviously, a lot more than if Jimmy had been able to purchase a Medigap during a guaranteed issue period, but still around $8,000 less than if he didn't have the Medigap at all. So even though he's still subject to this pre-existing condition exclusion period, he can still save money. Plus, after the first 6 months, the pre-existing condition exclusion is not an issue. Like for future years, for whatever future care he needs, he'll be covered in full despite the fact that he has cancer. Just as a quick reminder, does it matter that Jimmy spends half his time in California and half his time in Florida? And the answer to that one is no, it doesn't matter because he has original Medicare. He's not subject to plan networks. He can go see any provider, whether he wants to be treated in California or in Florida. So what is Medigap not going to help you with? The short answer to that is it's not going to help you with anything that isn't covered by Medicare Parts A and B. Medigap is just a supplement to Medicare. It is not going to be your solution for getting coverage for things like basic vision care and dental care or hearing needs. It doesn't have an impact on your prescription drug coverage. It is just supplementing and paying out-of-pocket costs from Medicare Parts A and B. So just to summarize where we are at this point, when we look at Medicare and we think about how do we want to get our Medicare, think of this as a road that has 2 lanes, and you can generally drive in one lane or in the other lane. Lane 1 is the original Medicare lane. You have Medicare Part A as your hospital insurance. You have Medicare Part B, which is your medical insurance. If you want coverage for prescription drugs, you're going to purchase a Part D plan. And if you want to limit your out-of-pocket costs from Medicare Parts A and B, you can select a Medigap plan. That's all in one lane. Lane 2 is Medicare Advantage, Part C, right? You choose one managed care plan that's going to bundle together your hospital insurance, your medical insurance. Like 90% of them will also include drug coverage, but if you pick one that doesn't, you likely can choose your own standalone Part D plan to go with it. What you can't do in lane 2 is buy a Medigap. Why not? Because in lane 2, in a Medicare Advantage plan, the plan is going to have an out-of-pocket maximum. How are you going to figure out which is the better lane to drive in? Let's go back and see Ted again. So when we last saw Ted, he was comparing 2 different Medicare Advantage plans. He figured out total cost for each of them, and one plan was several $1,000s cheaper than the other, which all seemed really good for him. But now some things have changed. At his weekly checkup, Ted chats with his doctor's receptionist, Ellen. Ellen tells Ted she's heard rumors her boss may be ending his contract with WellCare, which was the Advantage plan that he preferred. And in Ellen's experience, Medigaps are better than Medicare Advantage plans anyway. So Ted decides he's going to look into that option. And he does his research. He finds out about the plans in his area. He narrows his choices to a Medigap Plan G, and then a high deductible version of Medigap Plan G. And Ellen tells him the high deductible G plans are much cheaper. Which of these Medigap options is going to cost Ted less money? So again, our Medicare plan comparison worksheet can help you with comparing Medigaps. It's a different page in that same document. So first, just like last time, you go ahead, you fill in the relevant information about the plan's name and what type of Medigap you're looking at so you can remember these things. And then you want to fill in all of the pricing information that's at the bottom of the page. So in this case, Ted is comparing the Excellus Blue Cross Blue Shield Plan G that has a premium of $243.80 each month. And he's going to compare that to a high deductible Plan G offered by Bankers Conseco. That plan's monthly premium is really low. It's only $52.53 each month. But the high deductible Plan G is called that because it has a high deductible. It has a $2,700 deductible. Just like earlier, we have to do some math for Ted. So we transfer the numbers that we added earlier to the next section. And in this case, option 1 is we're going to add 12 months of our Part B premium, 12 months of our Medigap premium, which is even higher than the Part B premium. And then we have to add the $226 Part B deductible, and we total at $5,130.40. The second option is that high deductible option. Again, we're adding 12 months of the Part B premium. We add 12 months of this plan's premium. We add the Part B deductible. And then we also have to add the deductible Ted would owe out of his own pocket, that $2,700. And here our total is $5,535.16. So Ellen, the receptionist at the doctor's office, was not completely accurate. The high deductible plan does have a much, much lower monthly premium, no doubt. But again, you have to look at total costs if you think that you are going to be utilizing as much healthcare. And when you do that, you see that in this case, the regular Plan G ends up being a few $100s less expensive. So Ted is now going to use our comparison worksheet to figure out whether he wants to go with original Medicare and not bother with an additional supplement, whether he wants to enroll in the Advantage plan, or whether he wants to enroll in original Medicare and enroll in the lower priced Medigap plan. Again, you're transferring amounts from other pages in our tool to the final page. Ted transfers all this information. You can see what happens if he enrolls in each of these scenarios, right? So at the top is the original Medicare scenario, no supplement plan. And we're estimating $10,000 as his Part B coinsurance because the only thing he knows for sure right now is that he needs that chemotherapy. But you can assume that the real amount is going to be higher than this because he's going to have other health care as well. Then the second rung of this ladder is original Medicare, plus the Medigap Plan G. And then the bottom is the pricing of that Medicare Advantage plan. In terms of cost, at least, it is clear which of these options is going to be the least expensive. But remember, cost is not the only thing we think about. And also, even with this cost, Ted still has not looked at prescription drug costs or selected a plan for that. And again, we're going to be talking about that in just a little while. So now I want to spend some time talking about Medicare's enrollment periods. Enrollment periods mean the times of the year when someone can enroll in Medicare or the different parts of Medicare, or the times when someone can make changes to how they are getting their Medicare coverage. So Medicare doesn't have just one or even just two enrollment periods. It has four main types of enrollment periods. So the first of these periods is what's called your initial enrollment period or your IEP. This is when someone is first eligible for Medicare. So if you are becoming eligible for Medicare because you're about to turn 65, your IEP is a 7-month period surrounding your birthday month. It's the 3 months before the month that you're turning 65. It's the month you turn 65. And it's the 3 months after the month you've turned 65. If you are becoming eligible for Medicare because you are about to have gotten to your 2 years of getting SSDI benefits, your IEP is a 7-month period surrounding the 25th month of benefits. It's the 3 months before that 25th month, the 25th month, and then the 3 months after that. Some people get automatically enrolled into Medicare Parts A and B. Other people have to go out and proactively enroll. If you are approaching age 65 and you don't get any Social Security benefits or Railroad Retirement Board benefits, and you want to get Medicare Parts A and or B, you have to go and sign up. You have to contact Social Security or contact the Railroad Retirement Board before you turn 65. You can also apply online at Social Security, at Social Security's website. And if you worked for the railroad, then you contact the Railroad Retirement Board. Even though you get 7 months in your initial enrollment period, it is better to sign up earlier rather than later, because the earlier you sign up, the sooner your coverage becomes effective. So just as an example, let's say my birthday is June 25th. If I sign up for Medicare during the 3 months before June, like it's March, April, May, my Medicare is effective June 1st. If I wait until the last month of my IEP, which in this example is September, I'm going to be waiting until October 1st for my coverage to be effective. The second period of time when someone can enroll in Medicare is called the general enrollment period. So if you didn't sign up for Part B, or if you're one of those people who has to pay for Part A and didn't sign up during your initial enrollment period, and you're not eligible for what's called a special enrollment period, which I'm going to talk about in a minute, then you can sign up between January 1st and March 31st each year. And your coverage starts the first day of the month following the month when you actually enroll. Just remember, depending on how long you delayed, you may be facing a late enrollment penalty. Once you make this decision, once you pick up A and or B, if you then decide you also want a standalone drug plan, or you want to get your coverage through a Medicare Advantage plan, you can do that between April 1st and June 30th, and your coverage will start July 1st. And again, just remember that if you've delayed your drug coverage and you didn't have creditable coverage, you may be looking at late enrollment penalties. Each year, there is also a fall open enrollment period. This is the time of year when anybody can make changes to how they get their Medicare coverage. Open enrollment starts October 15th. It continues through December 7th. You can actually make as many changes as you want to your Medicare coverage during this time period, but the last change you make is the one that will then become effective as of the following January 1st. This is the time of year when you get to make changes that we were talking about earlier to try and make sure that you have a plan that is going to work for you. This is your chance. If you want to move from original Medicare to a Medicare Advantage plan, or you want to switch from Medicare Advantage to original Medicare, or you want to change which Advantage plan you have, or which Part D plan you have, or you want to switch your Medigap with the limitations I described earlier, all of these are things that happen during the fall open enrollment period. And this is really just designed to show you visually what I'm talking about, which is that ability to change lanes during this period of time. So maybe you have been very comfortably driving along in lane 2 for several years, but this past summer you were diagnosed with cancer. And all of a sudden, you would like to see a bunch of doctors or be treated at a hospital that is not in your Advantage Plan's network. Open enrollment is the time of year when you can change lanes and switch back to original Medicare as of January 1. Then there are what are called special enrollment periods. These are periods of time when people can sign up for different parts of Medicare coverage. And if you sign up for coverage during a special enrollment period, you may be able to avoid a late enrollment penalty that you otherwise would have had. So to complicate things, Medicare has different kinds of special enrollment periods for different parts. So this slide is only about special enrollment periods for Part B, and for Part A, if you have to pay for it. If you don't have to pay for Part A, if you get it premium free, you can enroll at any time after you are 65. And your coverage is actually retroactive by 6 months back to the original date that you were eligible to have it. If you are eligible to get Part A, again, premium free because you're disabled, you are actually automatically enrolled at the time that you would be getting your 25th month of Social Security disability benefits, and you would have to proactively disenroll if you didn't want the coverage. So again, this slide is focused just on Part B and Part A if you have to pay a premium for it. So sometimes what happens is it doesn't make sense for someone to sign up, for example, for Part B when they turn 65 because they're still working coverage through their employer. This special enrollment period gives someone 8 months after the earlier of either their employment ending or their health insurance coverage ending to sign up for Part B without a penalty. For a long time, this was the only Part B special enrollment period. It was the only way to delay enrolling in Part B. But we got some new special enrollment periods this year. They're limited, but they're an addition to what we have always had. And so you can sign up for premium Part A or Part B in what Medicare is calling exceptional circumstances. So for example, you couldn't enroll because you were impacted by an emergency or your state declared a disaster, or you got bad information from your employer or from your current group health plan about the need to sign up. These are all circumstances that may qualify someone for a special enrollment period. And then the length of those special enrollment periods varies, but they're generally around 6 months. Now, there are totally different special enrollment periods that are available if someone is looking to sign up for a Medicare Advantage plan, Part C, or a Part D plan. And if you go to Medicare's website, you can still see a full list of all the different circumstances. What's on the slide is definitely not exhaustive. Excuse me, some of the commonly used special enrollment periods that we see are if someone moves, in which case they're going to be eligible for sometimes completely different plans because what's available in someone's area is linked to where they live. There is also, a special enrollment period if you have lost employer-sponsored drug coverage that is creditable. So again, you can see details of all of these different circumstances if you go to Medicare's website. One more enrollment period that I want to mention is specifically for people who have Medicare Advantage plans. They get a special enrollment period each year between January 1st and March 31st when they can change Advantage plans, or if they have enrolled in an Advantage plan and decide, you know what, this isn't for me, I want to go back to original Medicare and I want to pick up a standalone Part D plan. So if you are someone who is enrolled in Medicare Advantage, just know that even after fall open enrollment ends, very quickly after, starting immediately with the new year, you will have another enrollment period that you can take advantage of if it would help you out. I want to just spend a minute or two more about Medicare and employer-sponsored coverage because we tend to get a lot of questions on that topic, and it is complicated, and there are a lot of nuances to it. So I talked to you about the Part B special enrollment period, but someone can also choose to have both Medicare and employer-sponsored coverage. And if they do that, then there are questions about how the two different types of insurance are going to work with each other. In other words, which of these is going to pay? Is Medicare going to pay first? Is your employer coverage going to pay first? Which one is primary? Which one is secondary? And the answer to that depends on two things. It depends on the size of the employer, and it depends on the way that someone became eligible for Medicare to begin with. So, if someone is eligible for Medicare because of their age 65 and older, if they work for a small employer, and by small employer in this circumstance, I mean fewer than 20 employees, Medicare is primary, it pays first, employer coverage pays second. If this person works for a big employer, which means at least 20 employees, the employer-sponsored coverage pays first and Medicare is secondary. If, however, the person is eligible for Medicare, not because they're 65 and older, but because of disability, in other words, they get Medicare because of SSDI benefits, if they work for a small employer, and here a small employer means fewer than 100 employees, Medicare pays first. And if they work for a big employer, which in this example, the employer has at least 100 employees, then the employer plan pays first and Medicare pays secondary. So this is, again, another example. Sometimes even as I'm saying it to someone, I'm like, I can't believe these rules are so complicated. There are a lot of these rules, and this is just sort of the tip of the iceberg. Medicare has rules for how it coordinates with all other types of health insurance too, like VA coverage and TRICARE and retiree coverage, et cetera. So this slide gives you a link. Medicare's website actually has a whole booklet about this topic, which is called coordination of benefits. In other words, what is the relationship between Medicare and another kind of health insurance? What about Medicare and COBRA? So this one depends on which came first. So if someone has COBRA first and then becomes eligible for Medicare, in most circumstances, their COBRA ends. But if someone has Medicare first, so for example, you have been working, but you chose to take parts A and B when you turned 65 anyway, and then you stop working and you were offered COBRA, you can actually get both. And in that circumstance, Medicare would be your primary insurance and COBRA would be secondary. It would act almost like a Medigap would. Why would someone get COBRA if they already have Medicare? That might be about wanting additional coverage. Maybe if your employer coverage covers some things that Medicare doesn't, for example. And obviously, if you do choose to have both, you have to pay the premiums for both. One other thing to look out for in this sort of Medicare and work context is how becoming eligible for Medicare can impact a health savings account or HSA if you have one of these. So for anybody who's not familiar, an HSA is a type of tax favored savings account for somebody who has a high deductible health plan. An HSA allows you to contribute pre-tax dollars, and then you can withdraw that money later and spend it on qualifying healthcare expenses, which the IRS determines what qualifies for that. What's important to understand here is that when someone enrolls in Medicare Part A and or Medicare Part B, they lose the ability to continue to contribute money to their HSA. That is because in order to have an HSA, someone isn't allowed to have any health insurance other than a high deductible health plan. The person isn't going to lose the ability to keep taking money out that's already in their HSA as long as they're doing it to pay for qualifying healthcare expenses, but they no longer contribute. And if they are contributing, they could face penalties. So just be careful about that. If you're already getting Social Security benefits when you turn 65, you're automatically enrolled in Medicare. So that could impact what you've been doing with that HSA if you're not sort of tracking the time carefully. So hopefully by now you have at least started thinking about like original Medicare versus Medicare Advantage and all the decisions that get involved if you want a Part D plan or a Medigap and the timing of it all. And all of this sort of comes down to, where am I supposed to start? So I showed you about our plan comparison worksheet, but where are you supposed to get all the information, like the examples I was using, putting in plan names and costs? And how do I compare a Part D plan? Because we didn't even go through that. So I want to introduce you to a tool that's available on Medicare's website that is called Plan Finder, okay? And this is a great place to start if you are looking for all the kinds of details I just described. So the first thing you want to do on the website is figure out which of these kinds of plans am I looking for information about. I'm in this example, use Part D plans, drug plans. And then the next step is to put in your zip code. I just want to note, like, you can either log in and do this, or you can do it as a guest. There is an advantage to logging in if you have a My Medicare account. And that advantage is that the account will know who you are and have saved information so that what you have to put in each time will be less. But if you don't want to have the account, if you don't want to be searching within your account, that's okay too. Then you can go through the tool and you'll answer a series of questions. If you don't know the answer to a question, I don't know is always going to be an option you can use. The tool asks you if you want to see drug costs when you compare plans. I always would say yes to this question. To me, the only reason to say no to this question is if you don't take any prescription drugs, because the price of your drugs themselves is it can dramatically change the overall price that you see of a plan if you don't look at the drug costs. You're also going to be asked questions about what prescription drugs do you take and what dosages and what quantities. And again, if you're someone who takes like a lot of prescription drugs, this can be time consuming, and that can definitely make it worth it if you have an account to log in so that all that information is saved for you. Next, you're going to be asked to choose pharmacies where you can compare prices. You can make sure that they're in network. You can see, where you're going to save money. You can choose up to 5 to compare. I like to include a mail order option. I like to always choose at least 2 big chains just to comparison shop. And then, of course, any local independent stores that you like to visit, or the place that's, the closest to your home. But you can do a fair amount of comparison shopping. Once you put all that information in, Plan Finder is going to spit out a list of all of the drug plans that are available in your zip code. So for the zip code that we did this search for, there are 23 plans. The tool will sort them in the order that's indicated on the upper right in the Sort Plans By box. The default setting for the box is to sort by lowest drug and premium cost. So you will see total costs, but you can switch those defaults if you want to search or sort, by different criteria. You can, for any of the plans listed, you can click that blue plan details rectangle, and you will get a lot of details about each plan, which I'm going to show you a little bit of in the next few slides. You can also check that box that says add to compare if you want to see a side-by-side comparison of a couple of plans. Let's say you wanted a Medicare Advantage plan as opposed to a Part D plan. It's a similar process. You just are choosing Medicare Advantage on that initial page when you're searching. So the options, though, if you search for Medicare Advantage plans, are going to look a little bit different because you get to see information other than just drug pricing information, right? You can see things like the monthly premium that an Advantage plan has, if it has one. Remember, on top of this, you're still paying that Part B premium that you're not seeing. Sorry about that. So let's look at some of the things that you can learn by using Plan Finder. Meet Kelly. Kelly turned 65 this year and lives in Chicago. She has high blood pressure and high cholesterol, but she's otherwise in good health. And she needs to pick a drug plan for the rest of 2023, which actually, one thing I just want to mention, if you go on Plan Finder today, you are still going to see 2023 information. And you're going to keep seeing that all the way through the end of the year, because of course there are people who, even though we're approaching open enrollment, there are constantly people who are aging into Medicare or reaching their 25th month of SSDI benefits. Starting probably at the beginning of October, when you go into Plan Finder, you're going to be able to make a choice. You can either look at information for 2024, or you can look at information for the tail end of 2023. So just be aware that both sets of information will be there for you. All right, so we're back to Kelly. Kelly needs a plan just for the rest of 2023. She puts in the drugs that she takes for her high cholesterol and high blood pressure. She puts in the pharmacies that she likes to go to. And Plan Finder shows her in her zip code in Chicago, there are 24 plans that she can choose from. And the one that shows up as being the least expensive overall is this Silver Script plan that you see on the screen. And Kelly goes through, she sees the monthly premium is under $5. And the total of all her costs for the rest of 2023, for like, call it September, October, November, December, she's looking at, under $50 total costs for this. And she likes this, right? This seems like it's going to work out for her. If she clicks that plan detail button, she can see even more details. She can see a side-by-side comparison of the price of each of the 3 drugs that she's taking at each of the 5 pharmacies that she entered. She realizes that in this case, Walgreens doesn't seem like a great option because of the 5 pharmacies, this is the only one that's not in network, but that's not a big deal to her. She's just as happy to go to Walmart or to CVS. Using Plan Finder, same tool, she can also see what her estimated costs are yearly or by month, based on the pharmacy that she's going to select. So if you're someone who likes to see the overall cost for a year versus being the kind of person who's like, I don't need that, I want to know month by month what I'm looking at, you can get this information in a variety of ways and view what is most useful to you. You can see that even here with relatively low cost drugs, though, there can be a big difference depending on where someone goes to pick up their medication, right? And here, obviously, you don't want to be going to that out-of-network pharmacy. Anyway, this all seems like fairly straightforward. But my question is this plan always going to be the right choice for Kelly? In the middle of picking her plan, Kelly is diagnosed with multiple myeloma, and her physician prescribes Revlimid. And she has to add that drug to Plan Finder to see how that impacts the total cost of drug coverage. Other than adding Revlimid, everything else about this analysis is the same for her. She's still on her other medications. She still chose the exact same pharmacies. But take a look how adding just one drug to the mix changes the whole story. Even though Revlimid actually has a generic equivalent, even the generic equivalent of it is tremendously expensive. Also, it turns out that when she adds this drug and sees her drug plan list and sees those 24 plans listed again, the Silver Script plan is no longer the top one that's listed. Now it's this Blue Cross Medicare RX Choice plan. You can also see that even within this plan, there's like $1,000 difference if Kelly chooses to get her drugs mail order versus going to a retail pharmacy. What's nice about Plan Finder, again, is you can see this information sliced and diced in all different ways. And you can kind of find what makes the most sense to you. You can see the side-by-side breakdown of the annual cost of each of these drugs by pharmacy. Notice also in this case, all 5 pharmacies turn out to be in network, and Walgreens by chance turns out to be the least expensive one overall. You can see another side-by-side comparison with estimated total cost. This is also where Plan Finder can tell you if you were never going to meet your plan's deductible during the year. Couple of other things to note with Plan Finder. You can open up a section called Other Drug Information, which will tell you a lot of good stuff. It will tell you what tier a particular drug is on. It will also tell you whether there are any coverage restrictions. So even if a drug is on a plan's formulary, there can still be restrictions on getting the drug. And there are 3 types that Plan Finder lays out here. The first is prior authorization. They tell you whether the pharmacy is going to have to call your insurance plan and get special authorization before it can fill a prescription for you. There are quantity limits where you can get a drug, but only up to a certain amount each month. I always tell people, don't necessarily assume the quantity limits are a problem just because it says yes here, because what you're getting might be under the limit. If you click on the little yes, you'll actually see the numerical amount. So you'll see 30 pills a month or 60 pills a month or whatever the limit is. And then there's also step therapy, which is where you have to show that a lower cost drug was ineffective for your condition, or it caused an allergy or some other adverse reaction before a plan is going to authorize giving you a higher cost drug. If there's a drug you take that's not on a plan's formulary, on this screen, you would see not covered under in that first tier column. Also, keep in mind that all this information that I'm showing you, I know that I was showing Kelly looking just at a standalone Part D plan, but if you're looking at a Medicare Advantage plan that includes drug coverage, you'll see all this same detail about the drug coverage benefits in the plan. Another thing you can do on Medicare's website is you can start your research about Medigap policies. So you can put in your zip code, and what Medicare will do is it will give you a list of all the different insurance companies in your area that sell Medigap plans. It'll give you some additional detail to that as well. Unfortunately, this tool is not quite as comprehensive as what is provided for Part D plans and for Medicare Advantage plans. So you do need to then contact the individual insurance companies to get pricing information or to enroll. Also, depending on what state you're in, some states, usually through the state insurance department, have some good tools to search Medigaps and to get this information in a very quick way. Other states, unfortunately, don't. So it's really just all about what your state provides. So as with other types of health insurance, if you don't agree with Medicare's decision about a claim, you have the right to appeal. Perhaps the most important paperwork you can get from Medicare when it comes to appeals is called the Medicare Summary Notice, or MSN. It's the equivalent of a private insurance explanation of benefits. It's going to lay out what the healthcare provider billed Medicare for and how Medicare processed the claim. It's where you're going to see information, for example, if Medicare believes that another insurance is supposed to pay first. And Medicare has procedures for both standard and expedited appeals. The different parts of Medicare have somewhat different appeals processes, but there are things they all have in common. So in original Medicare, it's 5 levels of appeal. It starts out with something really basic, which is just asking for a redetermination. You take your MSN, you circle whatever it is you didn't agree with. There's a space to write your reasoning about why you disagree, and it gets returned to what's called a Medicare Administrative Contractor, or a MAC, which is basically a private company that Medicare is using for billing. And if you disagree with the MAC's determination, you can keep pursuing your appeal up to, in some circumstances, all the way to judicial review in a federal district court. If you have an Advantage plan, the appeals process has a similar 5 levels, but the first step is going to be going back to your insurance plan and asking the plan to reconsider. And it's similar in a Part D plan, because again, these are private plans. Your first step is going back to a plan and saying, I want you to reconsider the decision that you gave me. I want to just take a second and emphasize how important we think it is to go through the appeals process if you get a denial. And we came across this study that Kaiser Family Foundation did that I think really, really show, like, they have good numbers to support the need to appeal. So in 2021, Kaiser looked at 35 million requests that were made for prior authorizations just submitted to Medicare Advantage plans. Now, the Advantage plans approved the vast majority of the requests. They only denied around 6% of them, which seems pretty good until you realize 6% is still denying more than 2 million claims. Of those 2 million denials, about 90% of people took no for an answer. They didn't do anything about it. They were like, okay, you're not going to give this to me, I'll move on. 11% of people appeal. That amounts to around 212,000. Of the 212,000, more than 173,000 of these claims get overturned in favor of the patient. It's more than 80%. Some of these plans, Kaiser broke down this data by insurance plan. Some of them were overturning more like 90% of their denials. So taking the time to file an appeal, sometimes just that first level gives real results and really can improve access to care. And then finally today, I want to wrap up by talking about financial assistance options. So I think all of our conversation today around cost shows that Medicare can actually be expensive. And there are some programs out there that exist to try and help people with those costs. So the first of these options is called Medicare savings programs. There are actually a few different types of these. There are 4 types. Each has its own name and acronym that you can see on the slide. These are all programs that help, excuse me, with Part B premiums, sometimes Part A premiums if you have to pay one. And then the QIMBY program, the most comprehensive one up there, that one helps with some other costs of Medicare too, like deductibles and co-payments and cost shares. Even though these are Medicare savings programs, these programs are actually run by each state's Medicaid office, because people, in order to have access to them, have to meet certain income requirements, and sometimes there are asset requirements as well. So if you are someone, or you are working with someone, or know someone who might benefit from one of these programs, the place to go to learn more and to apply is your local Medicaid office. There is also a federal program that helps with the costs of Medicare Part D. This is called the Low Income Subsidy. Sometimes it's called LIS, or referred to as extra help. This year, there are 2 types. There are full and partial extra help. That is actually going away, and beginning in 2024, it's only going to be full extra help. Anyone who's under 150% of the federal poverty level will be eligible for full extra help. In addition to that program, and that program, it is federal, it is run through Social Security, so that's where you would go to apply for extra help. In addition, in some states, not all, but some, there are what are known as state pharmaceutical assistance programs that also provide assistance with Part D costs. And you can look on Medicare's website to search whether your state has one of these programs. Enrollment in extra help can be automatic if you are someone who already gets full Medicaid, or you have a Medicare savings program. But in general, the income level and the asset level to get extra help is a little more generous than Medicaid or Medicare savings programs. So you can also, maybe you're not someone who'd be eligible for Medicaid or an MSP, but you could still get extra help by applying directly, by calling, or otherwise contacting Social Security. Full extra help has a lot of benefits to it. And one of which I just want to highlight is it's not just about money, it also allows for someone to have a special enrollment period where they get to change their drug coverage as much as once each calendar quarter. So for the first 3 quarters of the year, they can make changes. And then again, during open enrollment, they can make another change. So they can frequently make changes in order to be sure that they are limiting what they are spending on drug coverage. And then also, remember, Medicare is not the only public health insurance program in this country. So it is possible, and I got this question recently, it is possible to have both Medicare and Medicaid. In fact, around 12 million people in this country have both. They're usually referred to as dual eligibles. In a situation where someone has both, Medicare is going to be the primary payer and Medicaid will be secondary. Medicaid is often referred to as the payer of last resort. They like it when any other insurance pays before they do. In most instances, if you have both, Medicaid is going to pick up all of those cost sharing amounts not covered under Medicare Parts A and B. It acts almost like it's a Medigap. And it can even cover some of the services that we've talked about that Medicare does not. I also just want to remind people that even though we have all of these programs, all of these public programs out there to try and help people afford the cost of Medicare, obviously that's not always going to be enough. It's not always going to, help them pay all the bills they have. And so as a reminder, if you use our Cancer Finances tool, we do have a section devoted to financial assistance where you can search for things like general financial assistance to help specifically with health insurance costs, financial assistance targeted to high prescription drug costs. And obviously, we're talking largely about private organizations that get to make their own rules about who is or isn't eligible for help, but do know that those resources are out there. Oh, sorry. So I want to say, obviously, we've spent a lot of time together today. Hopefully, this has been a good either introduction or a review for all of you. But I recognize that, I see a lot of questions and coming in. I know people will have questions about things that I wasn't able to get to because we're limited in time, or they may have questions that are specific to their own situations. And I do want to highlight a few good places to go for help. So Medicare each year publishes a desktop reference called Medicare and You. I don't believe the 2024 version is out yet. They will mail it to everybody who's on Medicare, but if you want to, you can also access it online through Medicare's website. I actually think it's a really useful guidebook. When you have basic questions, it is a good starting point. If you're trying to review different elements of Medicare. Obviously, we walk through the Plan Finder tool. And of course, you can call Medicare and speak to an actual human being if you say agent. What I really want to highlight on this slide are state health insurance assistance programs, or SHIP programs. The federal government funds a SHIP program in every state. And through this program, people provide free counseling to people who get Medicare, to people who are becoming eligible for Medicare, and to caregivers. SHIP programs will help people do Plan Finder searches. They'll help answer questions about Medigaps in your state. They are great resources to start out with if you have personal questions. You can use our website's state resources section to look up contact information for your state's SHIP. I will just caution that just like everything else with Medicare, it can be a little confusing because not all states call their SHIP program a SHIP. So if you're in New York or California, they call it HICAP. If you're in Florida, I always like this one, they call it SHINE. But just know that every state has one of these programs. Also, of course, you can use our Medicare resources. We hope that they are helpful for you. We have a whole topic page on Medicare and cancer where we can link you to our many quick guides on the topic and to animated videos. There'll be a recording of this webinar. So please don't hesitate. That is also, by the way, where you'll find the link to our plan comparison worksheet. And with that, I know that, and I am grateful that my colleagues have been on answering questions throughout this presentation. I don't know, Nicole, if there's anything that should be asked out loud at this point, or if you've gotten to everything. And I know we're short on time.
I do not think there's anything that needs to be answered out loud. I will be getting to the remaining questions by the end when we close out.
All right, thank you so much. And with that, I'm going to throw this back to end us off. And thank you all again for attending.
Thank you so much, Amanda, for that wonderful presentation. And I would like to remind everyone that a recording of this webinar will be made available on our website by the end of the week. You can navigate to the events tab on our website, click past webinars, and then you'll see our full archive of webinars, as well as resource documents pertaining to each topic. So we hope that you enjoyed this webinar. And to close, we would like to emphasize that this isn't your last chance to learn with Triage Cancer. So if you're interested in learning more about today's topic or any of the topics on the screen, we invite you to attend our Apex event, the Triage Cancer Conference. We offer this day-long event biannually and free of charge to anyone in the cancer community. Sorry. We cover key information on how to navigate practical issues, minimize the financial burden of a cancer diagnosis, and reduce stress. And we also provide free contact hours and continuing education credits for healthcare professionals. And for the healthcare professionals on today, we greatly appreciate the role you play in changing the lives of individuals impacted by a diagnosis. And we also recognize just how vast all of this information is. So to meet this need, we created the day-long insurance and finance intensive just for you. This training is also free of charge, and it takes a deep dive into health and disability insurance, employment, and finances. And this program also provides free continuing education credits for healthcare professionals. You can view our full schedule and register directly on our website. And as a reminder, if you have questions about your individual situation, or if you have questions relating to this webinar, you can contact our free legal and financial navigation program by filling out a brief intake form online and scheduling an appointment with our staff. So we hope that you will continue to stay connected with Triage Cancer. We invite you to attend more webinars and other events. And we also encourage you to sign up to receive our blog and connect with us on social media. I personally really like our blog and our newsletter because you can use the QR code on the screen to sign up, and then it just pops up in your inbox once a month, and you don't need to remember to check our website for important news related to the cancer community. And I'm also going to drop the Flower Power fundraiser link in the chat right now. As a reminder, that is open, so you can get your bulbs for the spring now. And for the healthcare professionals on today, or individuals looking to distribute materials to your community, you can use the materials request form on the screen to order printed materials, and we will ship them to you in bulk for free. And as a last reminder, in order to receive continuing education credit for today's webinar, you must have stayed on until the very end. You will receive an email tomorrow from Zoom, which will contain a link to the evaluation and the post-test. The evaluation requires your name and your email address so that we can certify you completed the evaluation, and that is also the email we will use to send the certificates to within 4 weeks. Please complete the evaluation and post-test within 1 week. And for the nurses and social workers, as a reminder, you must also receive a passing grade of 80% on the post-test in order to receive credit. So if you see this message once you've completed the evaluation and the post-test, your submission has been logged, you passed the post-test, there's nothing else you need to do, and you will receive your certificate within 4 weeks. Now, if you receive a score that is less than 80%, you will see this message, and it will include a link to retake the post-test. All you need to do is copy and paste that link into your web browser. You do not need to do the entire evaluation again, just the post-test. And if you're having difficulty accessing the retake, please email info@triagecancer.org, and we will support you. Thank you all so much for attending today. We hope that you found the information useful, and we hope that you all have a great rest of your day.